Welcome to this new episode. Today, we're diving deep into pediatric cardiovascular conditions, focusing specifically on congenital heart disease and acquired heart disease in children. It's a complex area, but one that's critical for anyone working in pediatric cardiology or related fields.
Absolutely. And, congenital heart disease, or CHD, primarily involves anatomical abnormalities present at birth that disrupt normal cardiac function. The clinical consequences usually fall into two main categories: heart failure and hypoxemia. Acquired heart disease, on the other hand, develops after birth and can affect either a normal heart or one with congenital defects.
Right, and acquired conditions often stem from infections, autoimmune responses, environmental exposures, or familial tendencies. But before we get into the nitty-gritty, it's important to emphasize the role of a detailed health history and physical exam in infants and children suspected of heart disease. That includes prenatal history and family history, which can be quite telling.
Yeah, the prenatal and family history can reveal a lot. For example, maternal chronic illnesses like diabetes or poorly controlled phenylketonuria, teratogenic medications such as phenytoin, alcohol or illicit drug use during pregnancy, and infections like rubella all increase the risk of CHD. And then there's the genetic side. Syndromes like Down syndrome, DiGeorge syndrome, Noonan syndrome, Williams syndrome, and Holt-Oram syndrome are all associated with specific cardiac defects.
Exactly, and the incidence of CHD in Canada is about 12 per thousand live births, with half of those infants showing symptoms within their first year. Critical congenital heart disease, or CCHD, which often involves duct-dependent lesions requiring early intervention, accounts for roughly a quarter of all CHD cases.
That's a significant proportion, and it's why pulse oximetry screening, or POS, has become such an important tool in newborns. An abnormal saturation reading increases the likelihood of CCHD by about 5.5 times. So it's a simple but powerful screening method.
Definitely. And the screening is most accurate when done after 24 hours of life, testing the right hand and either foot to minimize false positives. It's a great example of how early detection can improve outcomes.
Speaking of detection, the physical assessment of suspected cardiac disease starts with general observation, looking at nutritional state, color, chest deformities, unusual pulsations, respiratory effort, and clubbing of the fingers. These signs can be subtle, but are often the first clues.
Right, and palpation and percussion help assess heart size, thrills, hepatomegaly, splenomegaly, and peripheral pulses. Auscultation focuses on heart rate, rhythm, murmurs, and any additional heart sounds. It's a comprehensive approach.
Then, of course, we have the diagnostic modalities. Electrocardiography, or ECG, remains fundamental. The standard 12-lead ECG provides detailed information on electrical activity, rhythm, conduction abnormalities, and ischemic changes. Holter monitors offer continuous rhythm assessment over 24 hours, which is invaluable for detecting intermittent dysrhythmias.
Echocardiography is really the cornerstone imaging technique. Using ultrasound, it visualizes cardiac anatomy and function in real time. There are several types: transthoracic, M-mode, two-dimensional, Doppler, fetal echocardiography, and transesophageal echo for posterior structures, or when transthoracic images are inadequate.
And cardiac MRI is increasingly used, especially for complex anatomy or vascular structures outside the heart. It provides excellent quantification of chamber size, function, flow, and tissue characterization without radiation exposure.
Then there's cardiac catheterization, which is invasive but offers detailed hemodynamic measurements, angiography, and interventional options like balloon dilation or device closure. It's divided into diagnostic catheterizations, right and left-sided, interventional catheterizations, and electrophysiology studies for arrhythmia evaluation and ablation.
The nursing care around catheterization is critical. Pre-procedural assessment includes accurate height and weight for catheter sizing, allergy history, especially to iodine-based contrast agents, and baseline pulse assessment, particularly pedal pulses. Post-procedural care focuses on monitoring for complications like bleeding, pulse quality, limb perfusion, vital signs, hydration, and positioning to prevent vessel injury.
Yeah, and despite all the technology, direct clinical assessment remains paramount. Monitors are adjuncts, not replacements, for thorough physical exams.
Shifting gears a bit, let's talk about fetal circulation and hemodynamics, which are essential to understanding CHD pathophysiology. In utero, oxygenated blood from the placenta enters via the umbilical vein, passes through the ductus venosus to the inferior vena cava, and preferentially flows through the foramen ovale into the left atrium, supplying the systemic circulation.
Right, and because the fetal lungs are collapsed, pulmonary vascular resistance is high, resulting in higher pressures on the right side of the heart compared to the left. Blood from the right ventricle is mostly shunted through the ductus arteriosus into the descending aorta, bypassing the lungs.
At birth, with the first breath, the lungs expand, pulmonary vascular resistance falls, and systemic vascular resistance rises as the placenta is removed. This causes the foramen ovale to close, as left atrial pressure exceeds right atrial pressure, and the ductus arteriosus constricts in response to increased oxygen.
This transition is critical. Any disruption can contribute to persistent fetal circulation or exacerbate congenital defects.
Exactly, and understanding hemodynamics is key. Blood flows from high to low pressure, taking the path of least resistance. So in defects with abnormal connections, blood shunts from left to right, higher pressure to lower pressure, resulting in increased pulmonary blood flow and heart failure.
Conversely, right to left shunts occur when pulmonary vascular resistance increases or there's obstruction to pulmonary blood flow, causing cyanosis due to desaturated blood entering systemic circulation.
And then there are mixed defects, where oxygenated and deoxygenated blood mix within the heart or great arteries, leading to variable hypoxemia and heart failure.
That brings us to classification systems for congenital heart defects. The traditional approach divides them into cyanotic and acyanotic based on the presence of cyanosis. But this is limited because acyanotic defects can develop cyanosis over time, and cyanotic defects may present with heart failure and a pink appearance.
Right, so the hemodynamic classification is more clinically useful. It categorizes defects based on blood flow patterns: increased pulmonary blood flow, decreased pulmonary blood flow, obstructive defects, and mixed blood flow defects.
Let's start with defects that increase pulmonary blood flow. These involve left to right shunts, causing volume overload and heart failure. Classic examples include atrial septal defect, ventricular septal defect, atrioventricular canal defect, and patent ductus arteriosus.
Taking atrial septal defect, or ASD, first, there are three types: ostium primum, ostium secundum, and sinus venosus. The left atrial pressure is slightly higher than the right, causing blood to flow left to right. Often, patients are asymptomatic, but may develop heart failure and have a characteristic systolic murmur with a fixed split-second heart sound.
They are also at risk for atrial arrhythmias and pulmonary vascular disease later in life. Treatment ranges from surgical patch closure for moderate to large defects to device closure, like the Amplatzer septal occluder, for suitable, smaller defects.
Ventricular septal defect, or VSD, is the most common congenital heart defect. Most are membranous, but muscular types exist. The left to right shunt here is more significant due to higher pressure differences, leading to increased pulmonary blood flow and right ventricular hypertrophy.
Heart failure is common in VSD, and a loud hollow systolic murmur is typical. Surgical repair is preferred, with pulmonary artery banding as a palliative option in complex cases. Prognosis is generally good for isolated defects but worsens with multiple or associated anomalies.
The atrioventricular canal defect is particularly interesting because it involves incomplete fusion of the endocardial cushions, resulting in a large central AV valve and combined ASD and VSD. It's the most common defect in children with Down syndrome.
Clinically, these patients often have moderate to severe heart failure and mild cyanosis. Surgical repair involves patch closure and valve reconstruction with operative mortality between 3 and 10%. Younger age and valve regurgitation increase surgical risk.
Patent ductus arteriosus, or PDA, results from failure of the ductus arteriosus to close after birth, causing a left-to-right shunt from the aorta to the pulmonary artery. Clinically, there's a machinery-like murmur, bounding pulses, and signs of heart failure.
Medical management includes intravenous endomethacin in preterm infants, while surgical ligation or catheter coil occlusion are options for others. Mortality is low, and complications are rare.
Moving on to obstructive cardiac defects, these involve narrowing that obstructs blood flow, increasing pressure proximal to the obstruction and decreasing distal pressure. Common examples are coarctation of the aorta, aortic stenosis, and pulmonic stenosis.
Coarctation of the aorta is a localized narrowing near the ductus arteriosus insertion. Patients often present with hypertension in the upper extremities, weak or absent femoral pulses, and heart failure in infants. Surgical resection with end-to-end anastomosis is the treatment of choice, with balloon angioplasty and stenting used in older children.
Mortality is less than 5% in isolated cases, but there's a risk of recoarctation. Postoperative hypertension is managed with intravenous medications like sodium nitroprusside and oral agents such as ACE inhibitors or beta blockers.
Aortic stenosis involves narrowing of the aortic valve, leading to left ventricular hypertrophy and decreased cardiac output. Newborns with critical aortic stenosis show poor perfusion, while older children may have exercise intolerance and chest pain.
Balloon valvuloplasty is usually the first-line treatment, with surgical valvotomy or valve replacement reserved for more severe cases. Recurrent stenosis is common, and valve replacement may be necessary over time.
Pulmonic stenosis is narrowing at the pulmonary valve, causing right ventricular hypertrophy and decreased pulmonary blood flow. Patients may be asymptomatic or have mild cyanosis if severe.
Balloon valvuloplasty is the preferred treatment, with surgical valvotomy rarely needed. Mortality is low, and although valve incompetence is common post-procedure, it's usually well tolerated.
Now, defects with decreased pulmonary blood flow involve obstruction to pulmonary blood flow with right to left shunting, causing cyanosis. Tetralogy of Fallot and tricuspid atresia are classic examples.
Tetralogy of Fallot includes 4 defects: VSD, pulmonic stenosis, overriding aorta, and right ventricular hypertrophy. The degree of pulmonic stenosis determines the shunt direction and severity of cyanosis.
Clinically, infants present with cyanosis and TET spells, which are acute hypoxic episodes. There's a characteristic systolic murmur. Treatment may involve palliative shunts initially, followed by complete repair with VSD closure and relief of pulmonic stenosis.
Operative mortality is under 3%, with improved outcomes due to early repair. Tricuspid atresia involves absence of the tricuspid valve, so blood flows through an ASD and VSD, with usually decreased pulmonary blood flow.
Cyanosis, tachypnea, and clubbing are common. Prostaglandin E1 maintains ductal patency initially, and staged surgical palliation culminates in the Fontan procedure. Surgical mortality is under 3%, but long-term complications include arrhythmias and ventricular dysfunction.
Finally, mixed defects involve complex anomalies, where survival depends on mixing oxygenated and deoxygenated blood. Examples include transposition of the great arteries, total anomalous pulmonary venous connection, truncus arteriosus, and hypoplastic left heart syndrome.
Transposition of the great arteries, or TGA, features the aorta arising from the right ventricle and the pulmonary artery from the left ventricle, with no communication between systemic and pulmonary circulations. Septal defects, or PDA, are necessary for mixing.
Newborns with minimal mixing are severely cyanotic, while those with larger defects may have heart failure. Treatment includes prostaglandin E1 to maintain ductal patency, balloon atrial septostomy to improve mixing, and the arterial switch operation in the neonatal period.
Mortality is around 6% for those with intact septum, but improves significantly with early surgery. Total anomalous pulmonary venous connection involves pulmonary veins draining into systemic venous circulation, requiring an ASD for systemic blood flow.
Cyanosis and heart failure are common, with obstructed forms being surgical emergencies. Surgical rerouting of pulmonary veins to the left atrium is the treatment, with mortality between 5 and 10% higher if obstruction is present.
Truncus arteriosus is characterized by a single arterial trunk supplying systemic pulmonary and coronary circulations, leading to mixed blood flow, increased pulmonary blood flow, and heart failure.
Early surgical repair involves VSD closure and establishing right ventricle to pulmonary artery continuity with a conduit. Mortality exceeds 10%, and multiple conduit replacements are often needed as the child grows.
Hypoplastic left heart syndrome involves underdevelopment of left heart structures with systemic circulation dependent on the ductus arteriosus. Initial mild cyanosis progresses rapidly after ductal closure, leading to cardiovascular collapse.
Treatment includes prostaglandin E1 infusion and staged surgical palliation, Norwood, Glenn, and Fontan procedures, or transplantation. First-stage survival rates range from 5 to 10%, but improve with early diagnoses and management.
Before we wrap up, it's worth emphasizing the critical role of nursing care post-cardiac catheterization. Monitoring for bleeding, pulse quality, limb perfusion, vital signs, hydration, and hypoglycemia is essential.
Positioning the affected limbs straight to prevent vessel injury. Educating families on site care and activity restrictions, and recognizing signs of complications are all vital. Despite advanced monitoring, direct clinical assessment remains the cornerstone.
So to sum up, congenital heart disease encompasses a broad spectrum of anatomical and physiological abnormalities with diverse clinical presentations. Understanding fetal and neonatal circulatory physiology is fundamental to grasping pathophysiology.
Classification by hemodynamics offers a practical framework for diagnosis and management. Advances in imaging and interventional cardiology have transformed outcomes, but multidisciplinary care, including vigilant nursing, remains critical.
And early detection, especially through universal pulse oximetry screening, significantly improves prognosis. It's a challenging but rewarding field, with ongoing progress benefiting countless children.
Thanks for joining us in this detailed exploration. We hope this discussion deepens your understanding of pediatric cardiovascular dysfunction and congenital heart disease.
Until next time, take care.